I would like to show you a diagram of the transition from the NHS as we knew it before this coalition government started through the time we are now, where the bill is being implemented now before it becomes law, and into the future once the bill is fully law. So what you can see here is the Department of Health handing down to strategic health authorities, there are 10 of those dotted around the UK, the money and the needs for the population and what needs to be done. And they farm that out to the 152 PCTs, which are in every locality, coterminous with local authority boundaries, who then commission healthcare from general practitioners and from trusts. So before this bill has become law, the government has set up the Shadow National Commissioning Board, which is the one that's going to take over functions of the Department of Health. It has merged the 10 SHAs now down to 4, and the 152 PCTs now down to 50 PCT clusters. And now the general practitioners have formed themselves into clinical commissioning groups, and they now, as you can see from these red arrows, they now tell the PCTs what to commission from the acute trusts, rather than the other way round, when the PCTs used to commission it sort of on their behalf, but without a great deal of intervention from the GPs and the commissioning groups. And as I say, the trusts are becoming foundation trusts now. That is compulsory. They don't have a choice. So they all have to become standalone, financially independent organisations. So this is the situation as we have it now. And I want to tell you that here on the ground there are a couple of things I need to explain. First of all, the GPs forming themselves into clinical commissioning groups has been heralded by the government as a mark of our enthusiasm to get involved with commissioning. This is not the case. PCTs were incentivised to get as many GPs into commissioning as possible, and we have been basically told that it's compulsory. We don't have a choice, and we've had to nominate in every practice a lead GP who goes and sits in the commissioning groups. I've spoken to a lot of GPs who are doing this. They're spending a half a day a month sitting in a meeting. They feel that what's actually happening is that they are being handed a template for how to commission, and that really their rubber stamping exercise for a foregone conclusion about what's going to be commissioned, and they don't really feel they have a say. Their own innovative ideas are not getting heard and are not getting implemented, certainly not at the moment. So once the bill becomes law, this diagram now evolves into the next stage. So this is the future, this hasn't happened yet, but the National Commissioning Board will become live. It will take over those functions from Department of Health, and in the process of so doing, it's bound to enlarge, because it's going to have meetings, it's going to have to go out on field visits, it's going to have to write reports and so forth. And in fact, the National Commissioning Board is set to become the largest quango in the UK. It will have £50 billion of your money, my money, our taxpayers' money to spend on healthcare, and it will be completely unelected. Those 4 strategic health authorities will not disappear, but they will become the 4 regional outposts of the National Commissioning Board. Those 50 PCT clusters will also not completely disappear, but most of their staff will be relocated into what are known as commissioning support organisations. The 50 PCT clusters that have become much smaller will not disappear, as I say, but they will become sort of local outposts, if you like, of the National Commissioning Board. They'll join with the 4 regional outposts and become the field force of the National Commissioning Board. Commissioning support organisations, it is possible to imagine that they might be taken over by private healthcare organisations. There's a lot of interest from some of the people that represent those organisations, such as McKinsey and KPMG, in getting involved with commissioning support. And their job will be on behalf of the clinical commissioning groups, those groups of GPs and other clinicians, to do roughly what the PCTs do now. So that'll be writing contracts, monitoring contracts, paying the money, ensuring that the providers that they've commissioned to do the healthcare work are actually doing what they are contracted to do. So the 50 PCT clusters, which are now much smaller, will join with the 4 regional outposts of the National Commissioning Board to become the field force of the National Commissioning Board, which will continue to deliver its work out there in the field. I would argue that there is very little difference between having those 4 regional outposts and 50 PCT clusters, that field force, as to what really structurally was present beforehand with the strategic health authorities and the PCTs. The National Commissioning Board will need to have some other functions. It will need to oversee the work of the clinical commissioning groups. It will actively commission GPs, because of course the commissioning support organisations who work for the GPs can no longer do that. They can't take over that function of the PCTs. The National Commissioning Board will also set up a new organisation, or 15 new organisations, the clinical senates. As far as I understand it, but they are very new, their job will be to ensure that the clinical commissioning groups commission care that is evidence-based and in line with good practice. Monitor, as I say, is going to become beefed up, and I've put that in lilac as well, as to represent the fact that it's because of its new functions, it can be seen as one of the new organisations of the new NHS landscape. The Health and Wellbeing Board is a fairly unknown quantity, but that is intended to be an amalgamation of commissioners from local authorities, from social care and from healthcare, who will join together, who will bring about joint strategic needs assessments that will inform both the clinical commissioning groups and the National Commissioning Board as to what is needed to meet healthcare needs locally. I've represented those in a paler colour because they are currently in shadow form, if in any form at all. Health Watch England, another new organisation which has recently been stripped of what statutory powers it was about to be allocated, is a body that is to represent patients' interests, your interests, within both the national and local commissioning arenas. That, again, is already faltering in its implementation. What you can see here in this diagram is not decentralisation. You can see the National Commissioning Board, now the largest quango in the UK, centrally dictating everything that happens around it via its field force. You can see, perhaps I think, not a reduction in bureaucracy. A very complicated structure, a lot of new organisations, relationships and functions have yet to be defined and formed. There's going to be a huge amount of instability while these things settle down. We are hurtling towards this structure to be imposed on us on April the 1st, 2013. Really, it isn't the case that there's been this huge clinical engagement that we hoped for, that everybody would welcome this with open arms. As you are aware, there are a huge number of organisations that are opposed to this reform. So I would argue that this is top-down reform. Exactly what we were promised by the coalition would not happen. So this is the landscape of the NHS once the bill has become law. And I think it shows 3 things. It shows the National Commissioning Board will rule everything from the centre. It's the biggest unelected quango. It holds a huge amount of our taxpayers' money, 50 billion at least. It's bigger than the Department of Health now and is set to become bigger than that once it really goes live. The second thing I think it's very easy to see is that there is no reduction in bureaucracy. Neither have the old structures completely disappeared, and we now have a huge number of new structures that are being imposed on us which nobody fully understands the functions of. And when you start getting inside into the detail and asking some challenging questions, as I have been doing, you find that nobody knows the answer. The third point I'd like to make about this new NHS structure is that really, to make it work, there is no hope of doing so unless we have clinical engagement, unless clinicians are genuinely enthusiastic and trying to make it work. It gives the lie to the idea that there is no top-down reform. This is very much seen by clinicians on the ground as top-down. It's been dictated to us. It's not our choice. I would also like to mention that that's actually a simplified diagram. That the integration between health and social care is not illustrated on this diagram. So there will be another new organisation, Public Health England, that had yet to be set up. That will be located within health authorities, and it's going to feed into the health and wellbeing boards. So that's another huge strand of work and strand of complication of this bureaucratic tangle that will come about. These diagrams that were published in the Financial Times show the more complete picture. This one is before the NHS white paper. This one shows the landscape after the bill becomes law.